Good evening and welcome to tonight's webinar. Dr. Vic Ross will present the science of one of the fastest growing segments in aesthetics, RF microneedling. Dr. Ross is past president of the American Society of Lasers, Medicine, and Surgery and is a leading dermatologist and widely recognized expert in aesthetic technology. During the webinar, please send in your questions and we will answer as many as we can after the presentation. Take it away, Dr. Ross.
Well, thank you, Brian. We're here tonight to talk about radiofrequency microneedling, and as the title suggests, setting the record straight. So when you look at radiofrequency microneedling, it's been around for a while, but we have a little bit of a misunderstanding and I think some confusion and controversy about the different devices, and there are lots of devices out there. We want to focus on tonight is the science of radiofrequency microneedling, the science of the needles, the science of the electrical current, the science of the power, and what steps have been taken to try to ensure that there's adequate energy delivery with certain devices, particularly the Genius. So one of the things that we try to address with radiofrequency microneedling is unmet needs. And we have a lot of unmet needs in dermatology, but some of those things are acne scars, facial wrinkles, the classic turkey neck where you kind of pinch your neck and it stays there for several seconds before it snaps back to the usual location, sagging jowls, the crepey neck skin and necklines, poor facial skin texture, and even lines off the face. When people go to work out, oftentimes they'll look above their knees and see these horizontal, almost Venetian blind type lines above their knees and other areas around the elbows. And these are types of areas that also are in the game as far as trying to try to make those better with different types of devices, including radiofrequency microneedling. So one of the things we see in young versus aging skin is a reduction in elastic tissue and collagen. And so if you look at this elastin collagen color graph, you'll see as we go from the left to the right in young versus aged skin, we see a marked reduction in that. So our skin really loses its snapback, almost like a slinky, where the slinky doesn't have that power to snap back anymore. So each year that reduces more and more. So our skin just doesn't snap back like it did when we were younger. And what we want to look at is ways to reduce that lack of elasticity and regain some of that snapback that we had in our skin when we were younger. A lot of the things we do in dermatology now are workarounds. We try to fill sagging skin. We try to lift sagging skin. We try to resurface sagging skin. But wouldn't it be nice to actually restore and replenish the reason why we have sagging skin, which is more than anything else, this loss of elasticity. So when we look at temperature and time are the key features in any event where we see denaturation of proteins. And at room temperature, at 35 degrees, even up to 35 degrees Celsius, which is quite hot, you really want to see a change in proteins. As we go to 35 to 45 degrees Celsius, we'll see some edema, some inflammation, and some reversible damage. And these are the types of things that happen when you do the motion techniques where you have a radiofrequency device with a metal plate and you roll it across the skin. You do get some slight heating of the skin, you get some reversible damage and inflammation. When you go to 45 to 62 degrees, you're talking about true denaturation of the proteins, meaning the proteins lose their form. And this is related to short-term contraction of collagen. Over time, this insult to the collagen, insult to elastin, will create new elastin and collagen and have a restoration of some of that protein to its normal state. So these are types of things that might be related to, for example, a device called Thermage, which is this confluent heating device. Now, as you move to 62 degrees to 100 degrees, you get permanently damaged collagen. You see changes on routine histology. You can see a complete color change on a routine H&E stain. You don't need a fancy stain to show a difference. And this is what we see with some non-ablative fractional devices, ablative fractional devices, and finally fractional RF microneedling. And this is one of the distinctions between microneedling and radiofrequency microneedling. Oftentimes people ask me, well, why don't I just use microneedling? And really it's the addition of the heat that makes those two procedures completely different. And of course, fractional is the mainstay of any radiofrequency treatment in this type of area where you're establishing and achieving high temperatures, because a non-fractional technique where temperatures exceeded 62 degrees would be doomed to cause scarring for the most part. After 100 degrees, you have ablation tissue, and it probably is not productive to go to that high a temperature. So you see the time-temperature combination is really what's important, and these were established, these time-temperature curves for protein denaturation about 70 years ago. So if you look at temperature, and we look from the lower part of this slide to the more superior part of the slide, you see this gradual change in the structure of the collagen fibers. And that's true for elastic fibers as well. Elastic fibers are somewhat more sturdy than collagen fibers. But you do see this slow change and loss of form of the structure as you go to higher and higher temperatures. At very low temperatures, like 41 to 45 degrees, as we said earlier, you're typically not going to see any permanent changes to collagen. You can elicit an inflammatory response, but we're not sure that really contributes to new collagen or elastin formation in a clinically useful way. So this picture is a very important picture because it shows the relative zones of where we're heating for the different types of devices. And if we divide the skin into the epidermis, which is roughly 40 to about 100 microns thick, depending on where we are on the parts of the body, the papillary dermis, which is really the most active part of the dermis, the upper maybe 100 to 300 microns of the skin, and then we have the reticular dermis, which is the most important part as far as the part of the skin that gives us its turgor and its form and function to some degree, is this large part just above the fat, which is the subcutis. So we have these different zones, and what's interesting, after all the time that we've had skin tightening going back almost 20 years now, nobody's really determined what the best place is to lay down these wounds. We know now that fractional wounds, more likely than not, is the best way to do this. A non-fractional technique is very challenging to do it right. But then we have these wounds all the way from superficial with lasers down to several millimeters down with ultrasound devices. So the question is, where do we want to put these wounds? Well, I think we want to put these wounds where the pathology is. And that pathology that results in skin tightening and also in pseudoelastosis changes are between maybe 400 microns to about 2 to 3 millimeters deep. So if we're in that zone, that's probably the best zone to be in. Now, many devices, you're stuck because of the way the needles are delivered or the way the ultrasound probes are delivered, the transducers. You have a very, very fixed range of where you lay down the wounds. And what one has to remember is the anatomy of the skin, the relative anatomy changes from region to region. So whereas 2 millimeters deep might be not so deep on the cheek, along the eyelid, that could be very, very deep. So one of the problems with many devices is the lack of adjustability to titrate the wound depth to the wound pathology. And when I say wound, I'm really referring to the wound of the skin damage and sun damage over time. So if you look at heat after 1 second with needle devices, what happens is, if you look to your right, as we deliver energy over time, the injuries on your right, lower right, between the needles become more and more closer together. So basically, we're trying to deliver heat, which is always going to be the greatest at the needle tip because the electrical field is greatest there. And over time, you see an evolution of that wound so that the wounds actually from the two adjacent needles touch each other. And after 3 or 4 seconds, you have some very large wounds. So if you look at the Genius, for example, on that slide again, you see that there's a way to adjust the depth of the wounds from as high as several hundred microns down to 3 or 4 millimeters. So the adjustability is great, and the ability to also change the size of the wounds depending on the time and power is important. So the clinical objective with all these devices is try to get sustained improvement of texture wrinkles without hyperpigmentation. And what we want to achieve, more likely than not, is about 30% of the volumetric dermis to be coagulated. And if you do that in a single session, that would be great because that seems to be the amount of skin wounding that, number one, the skin can tolerate, number two, results in a clinically identifiable change. So if you do very low numbers, you're going to have problems. If you only damage 1% or 5% of the volume of the dermis, you're more likely not going to have very little clinical change at all. And we'll talk later about why that's important, and that's why we might not be getting great results with some of our radiofrequency microneedle devices. So some of the limitations of past technology, if you look at full thickness ablative resurfacing, it's a great technique as far as the results, particularly for superficial skin damage and superficial tightening and color changes. But the problem is there's substantial downtime and pain. This is the traditional high energy CO2 resurfacing. And the biggest problem is a high risk of pigmentation changes, scarring, infection, which have been problematic since 1994 when the procedure became popular. Bulk RF devices that coagulate down several millimeters, again, these are large wounds. The heating is mild but large scale, and no one really knows what happens over time with these devices. They've been around now for 15 or 20 years. So here we're delivering energy. It's akin to having a barrel of water and heating it up a little bit over a large volume. And in large volume, low temperature increased devices, again, we don't know really what they do long term. They seem to achieve some mild tightening, but results are typically not predictable. Fractional ablative devices, less than 1.5 millimeter depth, which are typical CO2 lasers and some Irving Mag lasers, certainly can be helpful, but they have the downtime associated with the wounds being superficial. And again, we're not really treating a substantial volume of the skin, and that volume we're treating is going to be very superficial. Non-ablative fractional devices, whereas they have lots of advantages compared to ablative technologies, you still have pigmentation risk, and they're really not ideal skin tightening devices because the depth is not sufficient. Ultrasound certainly can go deep. It has the capability to go very, very deep, but the wounds are created are typically associated with significant pain. The technology is very expensive for the patient and the physician. It's very time consuming. And the results, again, because the depth is so great, oftentimes we don't see results early. And because the skin anatomy changes, relatively speaking, from area to area, sometimes 3 or 4 millimeters is not the optimal depth, and sometimes too deep, most likely to achieve a predictable response. So RF via microneedles has some decided advantages. You can bypass the epidermis, and certainly if the epidermis is a problem, you can involve other technologies for that, visible light technologies and superficial ablative technologies. You can deliver the energy in a quantity and depth that's desired for all skin types. So you can titrate and tailor the injuries to accommodate what you're trying to treat as far as anatomy and pathology. Lots of different conditions. Again, we talked earlier about unmet needs. Well, here are typical unmet needs: acne scars, wrinkles, texture, tone, laxity. Manageable pain, minimal side effects, particularly with the insulated needles. You're not involving the epidermis. The wound depths are predictable with certain needle arrays. And all layers of the dermis with the radiofrequency microneedling can be treated because you can adjust based on just turning a wheel or setting a dial on the graphical user interface. You can change the depths of the needles to a specified amount. And again, by changing the power and by changing the time, you can actually design controlled coagulation zones ranging from very, very small to the grain of sand, even to a grain of rice, if you wanted to achieve it that way. So how does radiofrequency microneedling work? Because in some ways, we talk about laser-tissue interactions, and while they can be somewhat, I think, challenging to understand, in some ways, radiofrequency microneedling is even harder to understand. The basic equation, though, is easy, and that is voltage is equal to current times resistance, and power is equal to voltage times current. So the voltage equals the current times resistance. We know that from basic high school physics. In the dermis and in the sub-Q and the other parts of the skin, those tissues are the relative resistances, or in alternating current terminology, impedance. And in a sense, it's a little different than lasers. So when you're talking about radiofrequency energy, the resistance of the dermis creates the energy. So the frequency, about 500,000 times a second with the Genius device, the device goes from positive, negative, 49 needles, back and forth, back and forth. It's the resistance, that alternating current, that creates the heat, that creates the coagulation, that subsequently creates the new elastic tissue and collagen formation. So each needle is surrounded by needles with opposite charge. The energy radiates from each needle. The electric field always will be highest right around the needle tip. And as the current encounters resistance, it's converted to heat. Over 65 degrees, even for a quarter of a second or a half a second, that's typically called the critical temperature. That's the temperature at roughly 1 second where you get collagen or elastic tissue, particularly collagen denaturation. So devices that do not reach the temperature are not going to do sufficient or establish sufficient changes to have long-term efficacy. And the clinical effect is based on the amount of tissue coagulated or the so-called volumetric density. Again, we're talking about 20 to 30% is probably ideal. In one treatment, you could certainly do less if pain limitations or other issues were at hand, but that's ideally what you'd like to do. A lot of devices, unfortunately, because the wounds are so small, which we'll show later, we're probably establishing less than 2 or 3% of tissue volume damage per treatment, which is just going to be adequate. It's really the proverbial needle in a haystack. Just not enough there to see something clinically relevant. Yes, you'll get some edema. Yes, you'll get some erythema, but you won't have that histology that's sufficient to show good results. So there was a study done by Hantosh et al., and this study is about 10 years old now. It was a very important study because they looked at 22 subjects, and they looked at elastic tissue stains and collagen tissue stains, and they really found with this radiofrequency microneedling device that you had new dermal tissue by 10 weeks. You saw vigorous wound healing and active dermal remodeling response, and what's most important, they actually saw almost a selective elastogenesis or creation of new elastic tissue, which was somewhat unique compared to other devices in the past. So this is a very important study. It's still relevant today. So look at all of the anti-aging treatments that we have, and this is a little cartoon that shows that if we look from left to right, we have insulated needles, which we're emphasizing tonight. We have monopolar bulk heating, which thermage is a good example of that, where we have some cooling at the surface. We have bulk low temperature increase heating. Then we have these bipolar devices where we have relatively superficial heating between a negative and a positive electrode, typically a rail-like electrode where you move the handpiece around. Not always, but most of these devices move the handpiece around. The heating typically is confined to maybe 1 or 2 millimeters. And then we have uninsulated needles where the needles are inserted and there's heating along the entirety of the needle, which can create some problems, such as PIH. So the coagulation zones, if you look, relatively speaking, for lasers, if you look at non-ablative fractional lasers, typically we're less than a millimeter. That's on your left. The ablative fractional laser in the middle. And finally, high-intensity precision radiofrequency. So the idea of Genius is being able to establish these small grain-of-sand-like injuries, which will become progressively larger as you go deeper. So you really want the snowman effect, where the deeper, larger injuries are there. Just superficial that, you have somewhat more smaller injuries, and as you approach the epidermis, even smaller injuries. Again, you don't want to have bulk heating near the surface because that could risk a small depressed scar. So again, the way we set this up is to try to establish a range of heating where you can establish critical zones of heating based on the time and temperature and the wattage. So here's a little histology. This is actually from the radiofrequency microneedling device. And if you look, the epidermis is preserved. And again, by going deeper with the needles with longer times and consistent powers, you can get larger zones. So again, the tailoring of the injuries is very important. So here's some fact and fiction. We always like fact and fiction. You see these types of shows on TV all the time or on podcasts, et cetera. So all needles go to the same depth set on the device. Well, most people say that's true. Why would somebody put on their graphical user interface a depth of 3 millimeters or 2 millimeters or whatever and not be confident that the needle was going to go in all the way? Well, the answer is false. And the falsehood of that is not based on necessarily intentional deception. It's just that the needles are not designed to optimize insertion. Here's a device, and if you look closely, you'll see the needles are pushing the skin away from the needle. So this is a device with several needles. It's set at 3 millimeters, but the needles most likely were getting in about half that, and not every needle is going into the same depth. This is using a kind of a low-powered servo motor, which pushes the needles in. But again, the skin doesn't want needles to go in. And again, it's like the bed of nails phenomena where somebody can walk on a bed of nails. It simply requires a very powerful motor and very sharp needles to make this work. So here's a study that was done in Journal of Drugs and Dermatology about 6 years ago by a device, not the Genius, with uninsulated needles. And what's interesting is in the paper, it was a very nice paper, they did lots of biopsies on pigs. What's interesting is if you look at the depths on these wounds from the study, they're all about 1/3 to 1/2 of the real depths. So the thickness of pig epidermis, and myself having done lots of pig studies, I can tell you in these pigs is roughly 60 to 80 microns. If you look at, for example, the slide to the far right, the picture to the far right, it says 2 millimeters. Well, I can tell you that's about maybe 0.8 to 1 millimeter. The 3.5 millimeter is more like about a millimeter. The 2.5 is even less than that, probably 800 microns. So what the point with this is that, and it was the same device you saw in the video earlier, is that the likelihood that these needles are going in all the way is small with some of these devices because there's no assurance that the needle is going all the way based on the structure of the motor, based on the structure of the needle tips. So all needles are the same. Well, one of the reasons the needles don't go in all the way, firstly, is the power that's used to push the needles in, the type of device that's used to push the needles in, which is very important. And secondly, the actual needle anatomy. So needles manufacturing, and this is false, all needles are not the same. Let's look at some needles. So you typically take your little needle out and you do Botox or whatever, and you assume the needle's very sharp. Well, needle sharpness can vary significantly. Look here to the left, you see this kind of graininess and little irregularities on the needles, all of them. Now, if you look at the Genius on the lower right, you see it's a very sharp needle. It's very smooth. And technology for this is very, very challenging to deliver these uniformly. So you have to start off with good needles. The needles really are the foundation of the best way to get the needles in. The needles have to be sharp. They have to be uniform. Let's look at some videos of some different needle insertion scenarios. So on your left, we'll look at the Genius, and you'll see the needles come down. And you see they're inserted fairly uniformly in this gel. And we go next, we'll see a competitive device. Happens to be the Secret RF. And you'll see here as the needles come down in the gel that you see that they're pushing the gel away from the needles. So some of the needles are going in further than others, but there's certainly a gap, maybe about a fifth or a fourth of the needle is not fully inserted into the gel. And these are all supposed to be 2.5 millimeter depths. Now look at this third device, and again, you'll see the needles come down. You have this erratic penetration. You'll see it come down. It's, again, pushing the gel away. This is supposed to be 2.5 millimeters. So it's interesting, in all of these scenarios, we're supposed to be 2.5 millimeters, but look across there. The only one that was truthfully going in 2.5 millimeters was the Genius. And you have a big gap. The effective depth simply is not what's on the interface. So when the user chooses the needle depth, you want to be confident that's the depth. It's like a speedometer in your car. If your car says you're going 60 miles an hour, you'd like to be going 60 miles an hour. The other issue is the impedance of human skin is the same for everyone all the time, and that's absolutely false. So impedance of the skin varies from wetness of the skin, from anatomic area to anatomic area. Oftentimes it's around 90 to 110 ohms. Ohm is the unit we use for resistance. But if we look here, for example, at just a simple map and navigating around the different parts of the face, you see we have low impedance with some zones because proximity to muscle, high impedance if we have thinner skin sometimes, a low impedance if we have sweating. So there are lots of different variations in impedance that are volatile as far as the way our skin behaves on a time scale. So consider the number of differences in a single person. So the device should be able to accommodate some of those impedance differences in real time. So without knowing what is happening under the skin, you simply can't give the correct amount of energy. So you can't simply design a device with a certain voltage, a certain resistance, and then hope that everything's going to work out. So here's a picture looking at the real power on the y-axis and the power on the graphical interface on the x-axis. And what you see with the Genius device is regardless of the impedance, you're getting the true power delivery. In other words, the I times V, the voltage times the current, is going to be fairly consistent between what you're seeing, and in other words, what you're choosing and what you're going to see. So again, the Genius is accommodating that by trying to look at the resistance and adjusting the voltage to maintain a constant power. So it's constantly looking for a way to make that work out. So the wattage settings on devices are the same as the wattage delivered to the skin. Well, that's absolutely false. So a lot of devices put a power on the screen or some number. It doesn't necessarily represent power, but a number that supposedly represents power. It could be a number like 8, but maybe the power is 30 or 40 because it's kind of a conversion factor. But nonetheless, the power on the screen may represent what the company's output power is supposed to be. But if the device has no features to have feedback, it will simply keep maintaining a power on the screen, but the real power delivered to the tissue can be quite different. So let's look at this. Let's look at this graph, which is very instructive. We have 4 different radiofrequency microneedling devices on this graph. And if we look on the y-axis, we see the actual power delivered to the skin. Again, that's the current times the voltage. On the x-axis, we see what's on the screen. So if one case, we see the screen says, say 75 watts to the far lower right. But what's really happening, only delivering 5 watts, because what's happening is the skin's drying out in the first part of the pulse, and then the rest of that energy or that time sequence is not delivering any further energy. So you'd like to have a scenario where the power you see on the screen is the power that's being delivered to tissue. And if you don't have control systems to monitor that, then more likely than not, you're not going to be delivering what you actually say you're going to be delivering. And that's very important because ultimately it's the heat that drives the clinical result. If there's no heat, there's no clinical result. That's very important. So the other issue that's important is insulated and uninsulated needles are the same. True or false? Well, that's absolutely false. So let's look at this little graph here. This is an uninsulated needle to your left. And what happens with an uninsulated needle is the radiofrequency follows the path of least resistance. So the highest damage is going to be in the papillary dermis. It's going to be somewhat lower as we get to the reticular dermis in the subq. And the epidermis will act as somewhat of a resistor. But what happens is, and just below that, you can have a higher current density just at the dermal epidermal junction, which oftentimes is what you don't want because that can cause pH. If you have an insulated needle, in the case of the Genius with a 0.5 millimeter uninsulated tip, the remainder of the needle being insulated, you have the spared superficial epidermal portion, which takes the energy away and the insult away from the dermal epidermal junction, which is a critical point for pigmentation disturbances and post-inflammatory hyperpigmentation. So let's look at this little graph, non-insulated versus insulated with a deep insertion to your right. You see the sparing of the papillary dermis, and you see sparing of the epidermis. Now, if you look at non-insulated needles, you see here that the papillary dermis is actually almost preferentially damaged because, again, this is going to be the lowest path of resistance. So an uninsulated needle, you're going to see sometimes the most injury where you want it the least. Now, another fact versus fiction is increasing the energy setting will always increase the energy delivered in the skin. Well, that's absolutely false, and we learned why. And this is very important. So the radio frequency is not the laser. Again, the laser energy originates outside the skin. Laser energy is absorbed, or light energy is absorbed, converted to heat. With radio frequency energy, the current is delivered to the skin, and because of the resistance to that current, we get heat generated. And it's the resistance and friction that causes the warring. Remember the Genius device, 500,000 times a second is going positive, negative, creating this electrical friction, which is the resistance creating heat. Now, these are all volatile and they're very nonlinear events. As you actually deliver this energy, even during a half a second pulse with the Genius device, things are changing all the time. The needle temperature changes. The resistance of the skin changes. So there are lots of real-time changes during the pulse, and the energy also affects this change. So you have to have a system that's monitoring this all the time to get effective energy delivery. Let's look at this. Let's look at impedance control versus no impedance control. If we look on the left, we see as we deliver the energy and the resistance goes up, at some point you're going to see a reduction in the delivered energy because it's not allowing for impedance changes. If the impedance goes up, the energy is simply going to drop off. So if you have a half a second pulse, but over the first quarter of a second, for example, you see an increasing resistance due to overheating of the skin or desiccation or drying of the skin. The remainder of that pulse is uneventful, no additional heat's being created, and you're going to have really tiny wounds which won't create for a clinical result. On the other hand, if you have impedance control where you're constantly monitoring the impedance to try to maintain a constant power, you have a much better chance of delivering the full complement of energy and therefore the full complement of heat and a more predictable clinical result. This is very important. These are some studies done where Lutronic looked at the neck and cheek of different people and in setting A, B, and C. And if you look at this graph, it's very important. You look at time is on the x-axis and the average power is on the y-axis. Now, what happens is you go to the first two slides, you see at relatively low powers, presumably without changing the resistance of the skin too much, you see fairly uniform energy delivery. So in other words, the power is maintained fairly consistently over a half a second. This is about a half a second time scale. Now, if you go to setting C, you'll see as the power increases beyond about 10 to 12 watts, in different people, you see this dropping of the power. And the reason that power is dropping is because you're seeing drying of the skin, resistance increases, and so you see the remainder of the pulse, the last half second of the pulse, or 50% of the duration of the pulse, there's no additional energy being delivered, no additional heat being created. But look at the variability from all these different patients. These are different subjects, and you see this drop-off point is very different. So for different parts of the body, for different people, you have a lot of variation as you approach these high powers. And if the system's not monitoring that, if the system's not providing feedback to make and accommodate those changes and deliver the remainder of that pulse, you're going to be delivering a lot less energy than you think in a very unpredictable manner. So this is a very important picture here. We'll start with, on your right, this is actually a device that's not Genius, and you'll see there's very little heat being delivered. So there's very little heat being delivered there on your right. More likely than not because the resistance has increased so much that no energy is really being delivered, so not real power. We'll go back and see if we can get the first one to go here. And Genius is on your left here. So you can't create volume on your right if you have no heat. Again, white represents heat. If you look at the temperature scale on the right, and we'll go to the next slide, and we'll see the Genius here. Now you see some heat being created because this whiteness represents heat. So the Genius, again, during that half a second pulse or quarter second pulse, it's actually monitoring the impedance, trying to make adjustments during the pulse to maintain constant power. So long as you keep a low enough power where desiccation doesn't occur, you can be assured you can deliver the full complement of energy that is on the screen. So if you put down on the screen 5 watts or 8 watts or 7 or 10 watts and you multiply that by the amount of time, remember power times time equals energy, you're going to get the full complement of energy. So if you have, for example, 5 watts and 300 milliseconds, that should be about 1.5 joules. Likewise, if you have another 8 watts and a half a second, you're going to have about 4 joules. So again, you should be able to multiply with the Genius the time times the power and get the real energy delivered to tissue. So look at the difference. If you have high intensity precision radiofrequency, which Genius represents, you can again tailor injuries to the size and depth that you desire. So you look at these wounds, they're about the grain of a sand size. They're roughly about 800 microns times 500 microns. They can be made larger or smaller. But look at the right, uncontrolled, imprecise energy delivery. These very small wounds. These are like 1/10 of a grain of sand. They're very tiny, And if you deliver this in one pass, you're talking about maybe 0.5 to 2% of the total dermal volume or skin volume being heated or coagulated versus 20 or 30%. So you can see that these tiny wounds delivered indiscriminately and non-predictably is not going to create a very good clinical effect and is akin to microneedling alone. And you can buy a microneedling device for certainly much less. And if you just want a microneedle, you're going to see results that aren't as impressive as the heat. That's a very important part of a good microneedle radiofrequency system. So look at the size of the wounds again, large versus small. And we see that these are much bigger. So even though it looks like it's only going to be 2 or 3 times as big, if you look at the volume of these cylinders or spheres is roughly 4/3 pi r cubed. So as the radius increases of these wounds, it's a much larger volume than the smaller wounds looking at one dimension. So fact and fiction, there are many clinical articles documenting the efficacy of RF microneedling, and that is true. There are lots of articles, but many are not very well studied or the studies are not well designed. So we have a lot of articles. There's a lot more information that needs to be out there. A lot of good articles remain to be published, I think, and a lot of the methods are not clear in some of these articles that you see listed here. So the efficacy is a function of settings used and energy delivered. Well, that's true. It's really a function of the energy delivered. You want to make sure that all of the energy is delivered in these systems, and you're much less likely to see that happen if you don't have a precision system that's monitoring the impedance during the pulse. So let's look at Genius. You can set the facial anatomy, pick apart the treat. There are lots of combinations of watts and time. You can choose lower watts and longer times, which gives you more of a chance of not over drying the skin and causing desiccation. If the energy is delivered too quickly, you can have issues. If the energy is delivered too slowly, we tend to see more pain. Pulse structure can be optimized for the tissue it's in. And the critical thing, again, is to really calibrate the energy to your desired outcome clinically and manage pain at the same time. So what are your desired treatment outcomes? So we've talked about the importance of needle depth, the importance of needle sharpness, the importance of impedance control, the importance of the type of power that's used to push the needles in. We've talked about insulated versus non-insulated, but let's talk about treatment outcomes because ultimately that's what we want. Now, here are some acne scarring pictures. This is Dr. Ibrahimi. Again, acne scars, more acne scars, crepiness of the skin, and probably crepiness is one of the major concerns that our patients have. Again, more before and afters for the neck and the crepey skin concern. And again, as we develop more and more sophisticated protocols for the Genius, we'll see even better results than these. So neck crepiness, this is one of the primary concerns of my patients. I think that anybody after age 45, I had a lady about 3 hours ago, 43, and had a significant amount of loose skin under the neck and was concerned about it justifiably. So the Genius represents a good non-invasive way to predictably design the wounds to accommodate the loss of elasticity and loss of collagen in the neck without a long, long recovery. These Venetian blind lines on the cheeks, these are a big problem. Again, trying to tighten the skin. You can try to fill these lines, but it's very, very challenging. This is another slide showing a fairly impressive tightening of the neck after 3 treatments, neck and jawline, again, face and neck. So can radiofrequency microneedling be used off the face or anywhere on the body? Well, that's true. And I think some other areas that we're looking at would be the armpit, and that could be for sweating or also just below the armpit for skin tightening, the abdomen for skin tightening, knees, above the knees, the elbow area where there's a lot of redundancy sometimes. Again, the critical thing is you're trying to establish new elastic tissue and new collagen to reverse some of the changes from aging, both from the sun and chronological aging. And again, trying to not have PIH. So in the end, we look at several features about microneedling. And the science of microneedling, again, as I said earlier, is challenging because it presumes an understanding of radiofrequency tissue interactions. And there's no great book. There are some books, but no one great book that really goes into detail about these types of interactions that not is unnecessarily sophisticated as far as mathematics. So really do an in-depth look at RF tissue interactions. You have to look at all these features of the skin, permittivity, and a lot of characteristics of the skin that are really challenging to understand as far as electrical phenomena. But even without an electrical engineering degree, even without a sophisticated knowledge of calculus and differential equations, the most important things, which we talked about tonight, is the ability to have a device that is able to control for impedance to some degree, adjust to try to deliver the full complement of injury, to try to reliably predict coagulation zones up to 30%, a precise needle insertion depth, which is guided both by very well-constructed smooth needles, number one, and a torque vector motor to get those needles to where they want to be, an easy-to-use handpiece where the motor does the work, proof of correct power output at treatment settings. So the other thing is look at photographs and look at where the photographs came from, try to determine if these are valid photographs. You know, settings, what do the settings mean? I think one of the problems we're having with the radiofrequency microneedling community is it really is hard. You read even some peer-reviewed literature and you look at the methods and you could not reproduce the experiment, which I think is a failure of the authors. In other words, if you don't know what you're doing on a microanatomic level as far as the wattage, the voltage, all these things, the electrical array, the way that energy is being delivered, you've done a disservice to the whole laser community and radio frequency community because you're not delivering the specifics of how your device works. You know, have these results been validated with data, and how can we make the device reliable enough, predictable enough to give you a higher return on investment? And of course, you always want to choose, regardless of the manufacturer, one that's going to give you good support, stand by their product. So these are all the things that we look at when we're doing I think, evaluation for any technology. And again, to evaluate and accomplish true 3D fractional, we want insertion accuracy, which we talked about. That's very important. That's related to the needle manufacturing, impedance control, which is related to the circuitry, and real-time monitoring of impedance to adjust the voltage accordingly to deliver the full complement of injury. And that gets back to genius, of course, which is related to intelligence. So again, this is a feedback phenomena. So we look at this and we look at the genius. Again, you want to have the technology delivered so you can actually get what you put into the system. And the precision is the most important part of the system, trying to have it each patient, each pass, where it works. And it gives you feedback. So if you're not getting all the energy in, you can have some ways to sort of improve that, which could be improving your technique as far as the way you hold the handpiece, changing the power, lowering the power. These are all things you can do to get the full complement of injury in. So the needle insertion is very important, the high torque motor, sharp needle design, that continual monitoring of actual impedance versus settings. So you're not just putting a setting in, you're actually monitoring the temperature or monitoring the impedance the whole time. Protocols have been validated through real studies, not just handing the device off and have somebody use it and see what happens. So those are very important types of things to look at. So if you look at precise control over energy delivered, again, you see that as temperature goes up, you start to see the coagulation change, the collagen changes, the collagen charring over 100 degrees. So you want to see the thermal profile that's confined along between the needles. Again, we're impedance sensing 500 times a second, and again, adjusting the energy based on real-time feedback to maintain optimal treatment. These are all features of a precision device. So if you do a real procedure, you're going to do over 50,000 plus microcoagulation zones on a face if you do the whole neck and face with the Genius device. And here's the interface here. We'll see this. And you can choose either energy mode or power mode and the depth. All of this is very intuitive. Here's the device being used. It's very easy to hold on to. You just hold it. Again, the device does the work. You just simply want to have a little bit of pressure. 49 needles in and out, in and out. This is an interval mode where it's automatic. You can go up to about 0.4 second off time. Of course, part of that depends on how long your time is per pulse. So it's a very reliable insertion, extraction, insertion, extraction. And Electronics committed to making things better, to developing new protocols. They have an in-house clinic where they're constantly looking at trying to make things better. So again, The critical features we've talked about before, it's really related to the technology. So the technology is better, and that makes for a more reliable procedure. And I think that the critical part is, again, delivering what you say you're delivering and realizing that what you say that you're doing on the interface is really what you're doing as far as the needle depth and the energy delivered. This is a new phenomena in radiofrequency microneedling because most of the devices simply don't do this. They just, you put the settings on the graphical user interface and hope for the best. So that's what we call intelligent care. And I hope you enjoyed the webinar tonight, and would certainly be happy to entertain any questions.
Thank you, Dr. Ross. That was a fantastic presentation. We have about 15 minutes or so for questions. Our first question, please use the Q&A box or the chat box, and we'll be happy to answer all your questions. The first question that's come in is this an effective treatment for sebaceous hyperplasia?
Well, the short answer to that is no. Certainly, if you do enough insertions, if you do, say, 1,000 insertions based on face and neck, which you could do, you'll inadvertently you'll hit some sebaceous glands and you'll actually heat them up. But if you look at the fractional component of sebaceous glands versus their denominator of where there's not sebaceous glands, I wouldn't think this would be a bona fide way to treat sebaceous hyperplasia. Again, you may indiscriminately destroy some sebaceous hyperplasia lesions like you would if you were playing the game Battleship or Minesweeper, but it wouldn't be a directed, selective way to treat sebaceous hyperplasia.
Great, thank you. A question about comfort with this new system. How does it compare in terms of comfort on an equivalent energy basis?
Well, comfort is typically going to be proportional to the amount of heat that you deliver. So there are two things that I think make procedures uncomfortable. One is heat. Number two is the actual needle insertion. In other words, when people report pain from any radiofrequency microneedling system, there are sort of two reports that your brain is processing simultaneously. It's the heat and the sting from the needle. And as those increase, you have more pain. I think what's unique about Genius is the needles are sharp, so the needle pain becomes much more tolerable. So if you take patients and turn the settings down so that the total amount of energy delivered per pulse is low, you'll have less heat and less pain. As you increase the amount of heat delivered per pulse, which is necessary, I think, and desirable for better results, the pain will increase. And at that point, you may have to introduce escalating doses of anesthesia. You could start with just cold air, then you would need cold air and numbing cream. And if you did very aggressive treatment, you might need cold air and numbing cream and even injectable anesthesia. So that's very dependent on the amount of energy delivered. What the device does, it minimizes the amount of pain per unit heat delivered. So that's good, but if you're going to really have phenomenal results, you're going to have to push the envelope a bit, and that will certainly be associated with a little bit more discomfort.
Great, thank you. Are you using manual mode, or are you using energy mode? And for users, potential users, what would you recommend?
Well, I tend to use the power mode in the time mode, so then I just kind of calculate the amount of, to me what matters, I know that there's two ways you can look at the millijoules per pin. Of course, you can multiply that millijoules times 49 and get the energy per pulse. I tend to think in terms of power and time, so I sort of set it in power mode and look at the time, and then I calculate in my head how much energy you're delivering per pulse, and that helps me to kind of see how we're going, and I look at the total accumulated energy, which the Genius reports cumulatively as you deliver pulse after pulse, and try to achieve between, say, 1.5 and 2 kilojoules for a face and neck. So that's the way I look at it, because I'm constantly looking at the power to try to manage the power to have the entirety of the energy delivered in any pulse, what I'm intending to do. So if I'm intending to deliver 4 or 5 joules or 3 joules per pulse, say at 4 or 5 watts, I want to make sure that that's what I'm getting. And if I look at power and time, I'm more able to do that. You certainly can look at millijoules per pin, and if that's more your preference, you can do that. That's sort of an individual, I think, preference.
So say specifically for, say, acne scar treatment, would it be more important to adjust the energy level with a higher energy, lower time, or lower energy, higher time, or does it matter? Just the total energy, or does just the total energy matter?
Well, I think with acne scars, there's two issues here. If you're treating a person who doesn't need real tightening, in other words, you're looking at small punctate boxcar scars in a younger person where there's not significant solar elastosis, I would tend to go to slightly higher powers and lower times. I really wouldn't want necessarily the wounds to be too large. As I have an older person who may have some solar elastosis and some skin loosening and acne scars, I would tend to go to lower powers and somewhat longer times to have larger wounds. So I would put more energy per pulse into a older person who has significant solar damage and acne scars, and less per pulse for a younger person. And that's twofold. One is the geometry and the characterization histologically of the types of wounds you're treating, and secondly, pain. Younger people tend to have a little bit more lower pain thresholds, and I would tend to want to lower the amount of energy per pulse to accommodate that as well.
Mm-hmm. Would you say, does vitiligo, is that one that, does it matter if somebody has vitiligo, or when you treat?
Well, somebody who has vitiligo, the question about vitiligo is the Kebnerization phenomena, and Suzanne Kilmer's reported this with CO2 resurfacing in patients who have a family history of vitiligo, maybe even having a personal history of vitiligo. There is a possible risk of activating the vitiligo. I have not seen that, and I have treated patients with vitiligo with Infinity Genius and CO2 lasers, and if I know they have vitiligo, obviously they see it, and we'll treat them, and I have not seen really a worsening of vitiligo with treatments for acne scars or treatments for solar elastosis. There's not a lot of patients I've treated that way, but I've not seen a big problem with that. And patients have been treated for vitiligo with fractional CO2 lasers and microneedling. So you have a little bit of a disconnect there. But if you really were concerned, you could do a test spot. If you were concerned about activation of vitiligo, that might be helpful, at least to guide you to see if the patient wasn't too susceptible to injury causing vitiligo or promoting vitiligo.
What are some of the other differences and advantages you see of the current Genius system or the Infinity system you used for quite a few years?
The Genius over the Infinity system?
Yes. Mm-hmm.
Yes. Well, the two biggest advantages of the Genius over the Infinity, number one is the sound, and that's related to the type of torque vectoring that is done with the Genius versus the Infinity. The Infinity had this almost staple gun type of sound, and it was just a little bit, I think, distressful for the operator and the patient. It was loud, and that was a little bit of a problem. And the second thing is the reliable needle insertion with the Genius and the reporting of the energy delivery. So with Infinity, it's a great device, but it does rely more, I think, on positioning of the needles, positioning of the skin, and you don't know for sure if you're getting all the energy in. The newer algorithms where you go to lower powers are more likely to put the full complement of energy, but it doesn't have the reporting. So I think it's the sharpness of the needles, the more, I think, palatable sound, and the reporting of the energy delivery are all advantages of the Genius. And also the interface. The interface is much more user intuitive. It's much more elegant. It's much more sophisticated. It's more like a smartphone. The Infinity was more like a flip phone. So I think it's just a big advance in a lot of ways.
Can you talk about depth? How has anything changed with your treatment settings in regard to depth since you've gone to Genius, or as we learn more over time?
Well, my depth settings are similar, but I think what I'm seeing, and that's just based on the reporting of the energies, I'm fairly confident looking at the device, looking at the skin, because I'm constantly looking at each pulse with my eyes, with my visor on. I certainly think we're getting more reliable insertions with the Genius than we were with the Infinity. And so I'm confident, I think at the end of a session, we're probably getting more energy in than we were with the Infinity over the same types of settings. So if I was multiplying time times millijoules per pulse or time times power, I'm confident now I'm getting 80 to 100% of that energy in. With Infinity, I'm not as confident as I was, particularly early on. When we had the Infinity early on, we were certainly not, I think, delivering all the energy we hoped for with these high powers in short times. So I think that's the big advantage there.
Yeah. So just kind of going back to the settings question. So again, a lot of people are wondering about, is using the millijoules per pin, is that easier, do you think, or for those that are used to using manual settings, should they, continue to use those?
Well, I think if you feel comfortable, the millijoules per pin is a good way to go. If you start using that a lot, you'll become comfortable with that. Again, just multiply. Like say you were doing 30 millijoules per pin. If you do that, that's certainly nothing wrong with that, and you'll end up delivering, say about 1.5 joules. You can do it that way, or you can do, 5 watts times 150 milliseconds. So it really depends on what you're comfortable with. But if you become comfortable with looking at the right side of the screen and you like millijoules per pin, that's certainly fine. I tend, again, just to look at the power and time and do it that way. I don't divide up the millijoules or the joules into 49 little increments. But there is some intuitiveness in that because it's kind of consistent with what we do in fractional lasers, right? When we talk about fractional lasers, we talk about 40 millijoules with the Fraxel, or we talk about so many millijoules with the LaserMD. So when we talk about different devices, that becomes intuitive. I think when we started doing fractional radio frequency needling, microneedling, we weren't talking in terms of millijoules per pin so much, but I think we're doing that more. And if that's more comfortable for the operator, certainly thinking in terms of that going forward might be a better way to approach it as far as looking at results and predicting results and feeling more comfortable with your fractional laser counterparts.
So a question about the tissue reaction with regards to bleeding, bruising, and then are you seeing a difference in day 1, day 2, day 3? Just talk about the whole post-treatment, the during and post-treatment skin reaction of the Genius, and again compared both now and compared to Infinity. Yeah, so we're certainly seeing almost no bleeding, and that was something we saw early on with Infinity. We were doing these high power short pulse durations and probably delivering not as much heat as we hoped for. As we changed to lower powers with Infinity, we saw a great reduction in the amount of even pinpoint bleeding after the case. And I remember initially when we did Infinity, we used to have a wet piece of gauze to wipe the blood off, and I don't think we even need that anymore. We almost never wipe blood off, maybe 2 or 3 specks instead of hundreds of specks. So that's been a big improvement. And that's true even when we went to Infinity in the later stages when we were lowering the powers. And I think we're certainly seeing less bruising with the Genius and the Infinity. And I think that's related partly to the needles being sharper and the needles going in more smoothly. I think there's less trauma to the surrounding skin as these needles are inserted and retracted somewhat more effortlessly than with the Infinity. So we do see swelling, we do see edema, but I think the results now with Genius and later Infinity is more akin to what we see after a relatively aggressive fractional non-ablative laser. Before we had that bleeding that would go away once we wiped it off, but we saw some bruising. I think we see a lot less bruising now than we did before, and I think that's partly related to the coagulation too. As you go to greater coagulation, even if you hit a blood vessel, you might be coagulating a part of the vessel as you hit it. So we just don't have the bruising like we did before. We're more likely to get bruising, to be honest, from local anesthetic if we do require that, than we are probably the device itself. Mm-hmm. Great, thank you. Can you talk about the yellow-green signal, when you might see it, and ways you might occur, and how you might reduce it if you do see it? So the greatest, I think, predictor of green versus yellow or orange is frankly, first of all, it's the thickness and the stability of the skin. If you go over a thicker area of skin, it's more turbid, more firm, the foundation is firm, you're more likely to get a green signal, regardless of the depth of the needle. As you go to more flaccid skin, particularly the concavities of the neck, maybe some looser skin along the jawline, and you go to fairly deep insertions, say 2 to 3 millimeters, then that predictable, reliable insertion of all the energy is not as good. And you can offset that. The first thing we do is we lower the power. Lowering the power is probably your best weapon, the first weapon, and getting good positioning of the device. I think holding the position completely perpendicular, getting the entirety of the base of the tip in full contact with the skin, gentle pressure, and lowering the power. Those are 3 things you can do to really increase your green rate versus your yellow rate
That's the first thing you should do. So that's the most important thing, is constantly monitoring your positioning of the device, looking at the device, trying to do your best to get all 49 needles, particularly at the corners, in contact with the local skin.
And does speed of how fast you're moving from pulse to pulse, does that have an effect as well?
Well, it's funny. I'd look at different intervals. Initially, I thought if I went slower, because when I would get a few yellows, I think, well, it's just because I've got it on interval mode, and I'm just going to take my time and do each pulse independently and just pretend like I'm a novice. And it didn't change as much as I thought. I thought if I really concentrated more on each pulse, it really was more related to the power and the anatomic location. And, as long as you don't go too fast. Obviously, if you're going so fast that the needles aren't completely inserted and retracted, then you're going to get yellows and oranges. But I found that overall, it's the critical thing, again, is it's the firmness of the skin. The firmer the skin is, the more likely it is you're going to get the full complement of energy in. And that's the key thing. And lowering the power is the first step I'd make on the interface as far as improving things. Sometimes lowering the energy or lowering the needle depth or reducing the needle depth can be somewhat helpful too. That can be helpful as well in some areas. But it's a struggle sometimes. You get a string of 30 greens and you get 2 yellows, and you get 30 greens and 2 yellows. And the key thing is, I think you're training your hand-eye coordination to get better and better. It's like the old movie Karate Kid, wax on, wax off. It really is. You're good at first, but you get better as you get your own feedback and hand-eye coordination, so you get more greens. And it's almost rewarding you with greens. It's almost a Pavlovian reaction. You get more greens, you feel better, and you get better at it, and you get more greens. And I think it's a very helpful way to get better with the device and deliver more energy more reliably.
Can we talk about post-treatment? What do you put on post-treatment? People are asking about PRP, other things that are being commonly considered to be putting on post-Genius treatment.
Well, that's a great question. So we normally just apply a gentle moisturizing lotion on after the procedure. Now, if you're going to do PRP, which we're not huge PRP fans, we've done PRP. We do it about twice a month, and usually for patients that ask for it. I've done PRP with microneedling, with Infinity, not so much with Genius. And I found it to be not as much of a big advantage as the device itself. I think the device is doing 90% of the work. And the PRP is, although it's easy to do, and if you're going to do it with the Genius, I would put the PRP on and then needle it in, probably do a pulse without any heating, because you don't really want hot needles, I think, pushing the PRP in. But I would actually do some less energetic pulses with very little energy to push the PRP in after you apply it topically. And then you can, of course, put PRP on the skin at the end, and some of that, although it's unknown how much, will actually go into those small holes. And, of course, you can do supplemental PRP with a 30-gauge half-inch needle and a 1 cc Lurlock syringe at the end as well. But I think the role of PRP is still unknown as far as both microneedling and radiofrequency microneedling. But there's no reason not to do it unless you don't want to have the expense for the patient yourself.
You mentioned earlier different devices can be used to treat the upper part of the skin, such as LaserMD, the total skin treatment. There's a question about when you do a total skin, would you also look at putting some of the LaserMD ampules into the skin as well?
Yes, you could certainly do that. You could do that at the end, do the Genius and then do the LaserMD after that. Some people would do the LaserMD first. I don't think it matters too much what you do. I would do the ampules. If you do the ampules, though, I do the ampules probably at the end. I wouldn't want to push some of those products that deep with the Genius. If you're doing the ampules, I would do the Genius first, and at the end do the LaserMD, and then apply the topical at the end, whether it's the vitamin C or one of the other topical ampules, and that would be a good way to go. And of course, you can do other types of technologies too to improve your results. But the total solution where you have the Genius as the foundation work and the LaserMD sort of like the paint and the foundation of the house is a good combination. It's a good 1-2 punch like beer and pretzels.
We've got a few minutes over our allotted time, so that sounds like a great place to stop. Thank you so much for this fabulous content and all your answers to these questions. For those questions we didn't get to, we'll try to send them along afterwards and get back to you with answers. Feel free to continue to send us questions, and we at Lutronic and Dr. Ross will do everything we can to get your answers to you. So on behalf of everyone at Lutronic, thank you for your attention and have a great night.